So we propose that we will have a discussion after first three talks. So next talk is mine. Yes, thank you. And thank you for opening, please. And whether would you? Yes. So the topic which I wanted to touch on is risk stratification and eventually how we could manage this risk.
I'm sorry, just a second.
Now it is. Now it is.
Thank you. So we wanted to speak about risk stratification and risk factors in LQT patients. And you already, all who participate are well aware of number of them, but just as a recapitulation of prior discussions and prior presentations, there are key factors which we know are affecting the risk of life-threatening arrhythmias, sudden death, QTC duration. If somebody is over 500, especially over 550, it's extremely high risk. We know that, as Dr. Goldenberg said a moment ago, sex plays a role, but somehow different in male versus female, where in male sex is associated with more life-threatening events in childhood, whereas in female after age 16, syncopal events are extremely important factors when we evaluate somebody's risk of potential aborted cardiac arrest. This is what ACA stands for, meaning that somebody had a cardiac arrest but was successfully rescued or sudden cardiac death. And in terms of genotype, specifically when we speak about those life-threatening events, LQT3 genotype is associated with more risk in childhood and at age after 40, whereas in the adulthood between 18 and 40, there is no clear distinction between three genotype regarding those hard endpoints. Just as recall from some publication done over 15 years ago, we look at a group of 570 patients at age of 18 to 40, so adults, and you may see the hazard ratio, meaning how many times more the person has risk of cardiac arrest or sudden death than person in opposite category. So here we have female versus male in general. It's about 3 times higher. And we speak about adults, as I mentioned. QTC, as you see, 3 times or 6 times, depending on the duration, versus those below 499. And syncope is extremely high factor, 10-fold increase. But you may see that there is beta blocker, which is 0.22, 0.22, meaning it's 5-fold decrease in the risk if somebody is on beta blocker. So we have those factors which probably every long QT patients and family should know. This is example from Dr. Goldenberg paper where we speak about age 1 to 12, when you see boys are at higher risk than girls at that age. And when we move to adults, as we mentioned a moment ago, women have much higher risk than male. And again, we speak about so-called life-threatening endpoints, cardiac arrest or death. And as you may see, difference is pretty big, because on y-axis, the black line for female goes up to 10% at the age of 40, which is pretty high for that age, obviously. I mentioned syncope. There is another paper from years ago, but very landmark important paper, which indicated that prior syncope increases very much probability in adolescence, but not only in adolescence, the same with adults. But as you see over here, it's for each category of QTC, which is on x-axis, we have increase in events in people with versus without syncope. So all these factors play a role. Another approach to look at those factors is to try to combine them. And we had pleasure to have Dr. Beaton who worked with us for 2 years, came as fellow from Israel, and we look at number of factors in people who had defibrillator implanted not for cardiac arrest, but for other reasons, as kind of primary prevention. And we found that risk factors that play a role include QTC, as I mentioned, prior syncope, especially if it happens on beta blocker, LQT2 genotype, and if somebody has more than one mutation matters too. And based on these few factors, we developed risk score, which was able to identify increased risk of appropriate ICD shocks in the future on over about up to 10-year follow-up. On the left, you see so-called Kaplan-Meier curve, where you can see that people with higher score of 3 or more, they go all the way up to almost 50%, whereas those lower risks could be identified too. And on the right, we have figure about recurrent arrhythmias. So obviously, predicting first arrhythmia is on the left, recurrent on the right, and we see that this combination of these few factors is effectively identifying high versus lower risk patients. And Dr. Mang, whom we introduced before, she has been working for a few years with us, and a number of other people have been involved in the project, as you see on this title of the paper published in October a few months ago, which focus on assessment of absolute risk of those life-threatening events in a combined fashion. And first important table in this paper, you should not really pay that much attention to numbers, but to the variables in the model. The same variables which I mentioned earlier, which we studied over decades, we tried based on higher and higher patients who collaborated with us, you all helping us collecting more data. We combined these parameters, including QTC, age, syncope, beta blocker use, and there is sex by time, meaning different role of sex at younger versus older age. And what was done by Mang and the team was to develop some model to predict 5-year risk. Why is it 5-year risk? Because over the last several years, the idea came that once we have some ability to predict 5-year risk, we may eventually be proactive with more aggressive treatment, whether it will be pharmacological treatment or ICD therapy. And the paradigm for this approach was created by hypertrophic cardiomyopathy about 10 years ago, when European Society of Cardiology established score specific for that disease, and they propose that if somebody's risk is below 4 over 5 years, 4% risk of aborted cardiac arrest or death, there is probably no need for implantation of ICD as prevention. If somebody is between 4 and 6, and you have here yellow color for this group, you are maybe at some risk justifying implantation. If somebody happens to be in the risk above 6, which is red in this figure, you eventually develop clear indication for ICD implantation. And this shows you complexity of the evaluation, because left part is women, right is men. You have 3 panels, age delineated, below 8 years, 13 to 20, and over 20. You have lines for QTC, we have lines for syncope, on and off beta blocker, and whether somebody is on and off beta blocker. So this table is pretty complicated. This is why we developed calculator, which I will show in a moment. But before going toward calculator, I wanted to stress that this first table is showing you key values at the time when you don't know yet genotype. And we know that number of patients were not genetically oriented, or we didn't have results of genotype. So therefore, you see a patient would like to evaluate herself or himself without knowledge of long QT gene. One could look at this table and have some orientation what the risk, what could be the risk at given age for given QTC, for given history of syncope and usage of beta blocker. However, these days, access to genotype is much better. Therefore, we also created LQT1, 2, and 3 model, which I will show for each genotype separately. So here you have LQT1, and as you may already notice, most of it is blue, meaning lower risk. Therefore, there are only some categories of patients who might not be in blue category. The on beta blocker is on the left for women, and on beta blocker is on the left for men. Please notice that all people who happen to take beta blocker over here, they are in low risk category. So they decrease their risk by taking beta blocker. The only categories, as you see, which are non-blue, both in the women and men, are those who are not taking beta blocker and had syncope on beta blocker, which is high risk subset. So we would like to stress again that beta blocker therapy, especially in LQT1 patients, is extremely effective. When we switch to LQT2, it's pretty much similar story with the difference that in certain age categories like adolescents, and you on left you have female girls 13 to 20 in yellow and on beta blocker still, and some boys on the right at age of below 8 in this borderline category. This is a little bit higher risk, as I mentioned earlier, could be indication for ICD, but it's further to be individualized. And on the right, you have some red areas, which are, again, if somebody doesn't take beta blocker. Most people can tolerate them, but obviously there are some people who cannot, so therefore people may proactively look at it. Lastly, LQT3, which is the least frequent out of 3, if we take 100% of long QT patients, we know that about 90% of them will have LQT1, 2, or 3, and therefore about 5 to 8% will have LQT3, remaining patients, about 40–45% will have LQT1, LQT2. This is what we know from current statistics. And LQT3 also less frequent, it has higher risk of events at various age categories. And unfortunately, they may require more aggressive treatment, including beta blocker therapy, despite the fact that it's less frequent arrhythmia. And as I mentioned earlier, this list score calculator has been developed. It's posted on CCRC, Clinical Cardiovascular Research Center website, and it's written on the left in the margin LQT risk score calculator. There is a link below to read the article from which I'm showing you these colorful pictures created by Dr. Wang, and PDF of the paper, which is fully accessible for you or anybody. And after one click, you can get to risk calculator, which could be filled by date of birth, gender, QTC, history of syncope, genotype, and you will end up getting the number which was presented in this colorful table. So instead of going through the table with exemplary QTC or exemplary age, one could be more precise here. And I want to stress that, as I mentioned earlier, that there are a number of ways to treat the patient. First of all, preventive measures, which you all know about, anti-adrenergic therapy, which is mainly beta blocker, but sympathectomy could be too, gene-specific therapy, sometimes pacemaker, and ICDs. I mentioned ICDs, but beta blocker, as I mentioned, is extremely effective, as it was shown in this paper, showing about 50% reduction in events. Dr. Wang, working with us on her PhD thesis, also looked at the risk of people who had implanted ICD and looking at the risk of first appropriate ICD shock. And you have people in blue who happen to have cardiac arrest before, and the risk of this next potential event was about 25% at 6 years, if you look at this curve. If you look at syncope on beta blocker, also pretty high, but interestingly, we found that also syncope of beta blocker, but in people who have quite prone QTC, this could be risky. So finishing, I want to state that these patients who receive ICD therapy, they have very effective reduction in mortality. You have mortality 46% reduction. Mortality censored by age 50. Why? Because obviously above age 50, you may have coronary disease, you may get other diseases at older age, cancer and other diseases which may affect our overall effectiveness of ICD, because of course defibrillator is working for arrhythmias. And here you have 71% reduction, which is pretty much very difficult to find for any therapy such effective, such great effectiveness. And when we analyze just sudden cardiac death, it came up to 78% reduction for all three of those indications which I mentioned earlier: aborted cardiac arrest, syncope on beta blocker, and people with very long QT and syncope while off beta blocker. So I want to finish thanking you, because this informed risk stratification that leads to optimized clinical decision making is really supported by decades of research, possible only due to devotion of long QT patients and their families. Thank you for helping us. And it's my great pleasure to introduce now Dr. Meng Wang, who is currently at Tufts University. Her career is going forward extremely successfully over there. Maybe one day we will attract her back to Rochester, but she will be speaking about some other part of her research done here, and I'm sure you will find it attractive. Thank you. Hank, please. Elon, we can